Antibiotic resistance and development today. Finding optimal treatment regimens is therefore critical in ensuring prolonged effectiveness of antibiotics. The topic is panel discussion on common infections and antibiotic prescription.
The chairpersons for this session are Dr. Sheela and Dr. Sai Krishna. Dr. Sheela, she did her UG at Raja Muthiah Medical College and DNB Family Medicine at Sundara Medical Foundation, Chennai. She did her fellowship in General Infectious Disease in CMC Vellore and is currently working as a consultant physician at Apollo Hospitals, Chennai. Dr. Sai Krishna, he did his MBBS from Osmania Medical College in 2010 and DNB Family Medicine in Kamineni Hospital, and he is now working as a senior resident in Kamineni Academy of Medical Science, and he is the author and editor for an illustrated handbook of family medicine.
Speaker for this session is Dr. Ayyappan. He completed his MBBS from Tirunelveli Medical College and MD Anesthesia and Critical Care from JIPMER Pondicherry and was a gold medalist, FNB in Critical Care Medicine at Fortis Hospital, Bangalore, worked as a consultant intensivist in CCMT at MMHRC for 3 years, KIMS Health Trivandrum for 1 year, currently working as consultant in CCMT at Apollo Specialty Hospital, Madurai. He published an original article on time course of psychomotor recovery after IV dexmedetomidine infusion as a part of balanced anesthesia technique, a randomized double-blind study in the Indian Journal of Anesthesia.
Good morning all. I am very delighted to see the fully packed session here, and a very important and very informative session it is going to be by Dr. Ayyappan. And as a family physicians, day to day we see this infections. Around 70 to 80% of our OP is going, we see the fevers. And what the most important bugging thing is seeing the super bugs and bad bugs in our OPD. So over to Dr. Ayyappan to enthrall us on how to deal with these bugs.
Good morning, one and all. It's a pleasure being here. It's actually a privilege being back here. I was here a year back as a consultant, and it brings me back fond memories of working here. And it's a privilege to be sharing the dais with the eminent faculties of this wonderful conference. So without wasting much of time, I'll go to the topic per se. It's a very vast topic. I'll try to do justice as far as possible. Definitely there will be some lacunas which can be answered during the questionnaire. So the topic is common infections and antibiotic prescriptions. I'll try to cover the common community-acquired infections first. So the talk will be basically on the epidemiology of the community-acquired infections and a brief note on the community-acquired pneumonia and urinary tract infection, which are the most common infections which we see in our day-to-day practice, and tropical fever syndrome, followed by antibiotic prescription. Basically depends on the PKPD principle, so we'll have a brief discussion about that, followed by the emergence of resistance, the mechanism of the same, and what are the newer antibiotics which are down the spectrum. Yeah. So looking at all these things, there is a general thought that the resistance is basically because of the treatment which is being given or the antibiotics which are being given in the hospital setup. But if you look at the literature and if you go at the epidemiology, around 70 to 3/4 to 4/5 of the antibiotic prescription, nearly 70 to 80% of the antibiotic prescriptions happens in the outpatient setting. So the majority of the antibiotics which are being given are in the outpatient setting. So the appropriate antibiotic therapy in the outpatient is a must for the appropriate recovery from the infection. Whether it is for an appropriate disease or it's a without an indication doesn't matter, but appropriate therapy will be associated with better outcomes, whereas inappropriate therapy may lead to emergence of new MDR infections. So what are the common infections which we see in our day-to-day practice? As an intensive care physician, the most common infection I see in my ICU is pneumonia. So around 25% of my hospital or my ICU patients will be pneumonia. Either it's community acquired or hospital acquired. Hospital acquired will be even more higher. And followed by urinary tract infection, and then followed by probably a tropical fever syndrome, which will altogether consume around 70 to 80% of the infective cases, that is community acquired infections in the ICU, followed by skin and soft tissue infections, meningitis, encephalitis and others, basically atypical infections. So a brief note on community acquired pneumonia. What is pneumonia? Pneumonia is nothing but the inflammation and consolidation of the lung parenchyma. And if it happens secondary to a infective process which is acquired from the community, it is community acquired pneumonia. If it is acquired from the hospital environment, it is hospital acquired pneumonia. So this is the, as far as WHO is concerned, is the fourth most common cause of mortality worldwide. So it causes significant mortality, significant health burden to the community, and appropriate management at the community level will improve the outcomes in this scenario. So in India, based on this epidemiologic study, which is a multi-center study, a observational study, there was around 20% of the hospital admissions were secondary to community-acquired pneumonia. It's a paper which was published 5 years back. And the most common organism, we tend to follow the Western literature, so the most common organism as far as Indian context is concerned. So if you look at the literature, it says strep pneumonia, pneumococcus being the most common community-acquired pneumonia organism, followed by staph aureus. But we don't see much of staph aureus or gram-positive pneumonia in our setting. Nearly nearly 1/3 of the infections are caused by, even community-acquired pneumonias are caused by gram-negative bacilli, most commonly by Klebsiella, followed by E. coli. That is the most common spectrum in our center. So following a Western guideline for treating these patients may result in under-treating the primary pathology. And as of community-acquired pneumonia is concerned, we don't have proper epidemiology because majority of them go undiagnosed. Nearly 80% of the patients who are treated on a OPD basis doesn't have an underlying, because we don't send sputum, and as far as recommendations are also concerned, they don't recommend a sputum culture if the patient can be treated on a community basis or a OPD basis. So we don't know exactly what is the causative organism for that. So if the empirical therapy is successful and the patient gets better, we won't know what is the organism. Once they don't respond to the therapy and if they get admitted, that is the time when we get to know that organism, and most of the time it will be a non-responding pneumonia. And the other thing is, majority of the community-acquired pneumonia in elderly as well as immunocompromised patients, they will have a atypical presentation. They will come with lethargy, drowsiness, or sometimes with sometimes they may have vomiting associated with it. That might have triggered the aspiration, and other atypical phenomenon is they will be having polymicrobial infections. Even in community acquired, they may have a polymicrobial infection. So as we all know, the risk factors for that is routine one, like older age, comorbidities, especially a chronic heart disease, chronic lung disease, or chronic liver disease, with cigarette smoking and alcohol abuse also also should be taken into consideration as the risk factors, and immunosuppression. So pathophysiology, it is either microaspiration in, as I said, in elderly patients, or inoculation of the microorganisms directly into the lung parenchyma through the oropharynx, and it stimulates the macrophage and release of cytokines, releasing the inflammatory mediators and inflammation in the lung parenchyma, causing the consolidation. So imaging. As far as imaging is concerned, this chest X-ray showing the right middle lobe and middle lobe consolidation and the lower lobe consolidation. The corresponding, you can see the air bronchogram in the CT. So the purpose of this image, this slide is, imaging is not routinely recommended for all the patients. Only patients who does not respond or who require hospitalization require imaging. All patients does not require even a chest X-ray. Even in chest X-ray, if you find atypical findings, or if the patient is not responding to your empirical therapy, probably they are the candidates for CT. So not all patients require chest X-ray, and not all patients require CT. So coming to the assessment of risk factors, so why do you have to assess the severity of the disease at the time of admission? So it serves in two purposes. One is to prognosticate the disease first. Next, for the safe disposal of the patient, whether the patient can be treated on a OPD basis, whether the patient has to be admitted. If admitted, whether in a ward or whether requires a HDU or a ICU admission. So there are multiple scores, there are so many scores. The most commonly used or the easier one is the Curve 65. I think everyone will be aware of that. So you have a score of 0 to 5. The patients who have a lower score have less mortality. It also has a mortality prediction tool also. It can also be used at it, and a score of 4 or 5 is associated with the mortality of even around 40 to 50%, and so they will require intensive care. So other scores which are commonly used are the ATS, IDSA, criteria for severe community acquired pneumonia. It has a major criteria and minor criteria, and this is basically for patients who require ICU admission and monitoring. So the other score which is commonly used is the SMART-COP score. So SMART-COP is a mnemonic where you can, SMART S stands for systolic, multilobar, albumin, and respiratory rate, tachycardia, followed by confusion, oxygenation, and arterial pH. If you have a score of more than 3, it's an indication that they will require ICU admission. Less than 3 can be managed on the OPD basis. So other scores are there, which is pneumonia severity index, which are very complex and it's not routinely used. So when you have a patient who comes with pneumonia, you look at the pneumonia severity index or the curve 65 score. You have a score of 0 to 1, you treat them on OPD basis. If you have a score of 2, then you treat them on a inpatient, and if you have a score of 3 or 4, you advise ICU or a HDU admission. This is the rationale behind assessing the severity. So treatment regimen. So how do we treat them empirically? So routinely every community acquired pneumonia patient who is treated on OPD basis, as far as they are mildly symptomatic or in the curve 0 category, can be treated with monotherapy with either fluoroquinolone or macrolide alone. In case they are symptomatic, or if they have to be given IP admission or has to be hospitalized, they require combination therapy. This is what the IDSA guideline says. And the combination therapy in the form of a beta-lactam plus a macrolide or a fluoroquinolone. Fluoroquinolone can also be used as monotherapy, but in Indian context it is better avoided. So if they have risk factors for MRSA, say what are the risk factors for MRSA? If your hospital or if the community has an incidence of more than 10% of MRSA, or if there is recent history of admission, if the patient is having CKD, or if there is previous antibiotic exposure within the last 90 days, these are all the patients who have high risk of MRSA. So they have to be, along with this, they have to be given MRSA cover. But the MRSA incidence in India is very low. Very rarely we have to give MRSA cover unless it is associated with the influenza A viral pneumonia. So other thing is pseudomonal cover. So when do you give pseudomonal cover? Pseudomonal antibiotic beta-lactam should be given if the patient has any structural lung disease. If the patient has a previous culture which has grown pseudomonas, or a patient is a COPD bronchiectasis patient. So these are the patients where you have to give a beta-lactam. The beta-lactam should be specifically a anti-pseudomonal beta-lactam. What are the anti-pseudomonal beta-lactam? Ceftazidime can be used, cephalosporin can be used, piperacillin tazobactam can be used, and this has to be combined with macrolide or a fluconazole, and in case where it is not available, aminoglycoside can also be considered along with beta-lactam. So what are the other investigations or the other adjuncts which we can use in a pneumonia? So first is the role of urinary antigens. As we said earlier, most of the times we don't get a diagnosis. So what are the other diagnostic modalities which are available? The rapidly evolving thing is the molecular based diagnostic, which is multiplex PCR. PCR based diagnostics are on the rise and it's being used everywhere because of the rapidity and the ease with which the decision making can be done once your PCR results are out in say 4 to 5 hours. No need to treat them empirically, you can start them on definitive therapy. If it is a if it is a viral infection, you need not treat them with the antibacterial at all. So these are all the benefits of PCR based therapies which we will discuss later. And other thing is the urinary antigen. So these are all kits or dipstick antigen tests which can be done at the bedside, and you get the results within a small duration of time, like a pneumococcal urinary antigen or a Legionella urinary antigen. So you put the urine in that, you will get the result, and if it is positive, you treat them for that. If it is negative, you need not treat them. There are flip side to it in the sense that it doesn't differentiate a colonizer from an infection. It doesn't differentiate a previous infection within the last 3 months from the acute infection. It doesn't give you a sensitivity pattern. These are the flip side of using a urinary antigen, but definitely in difficult cases where you start your empirical antibiotic therapy with the beta-lactam, where the patient is not responding, you can always go for Legionella urinary antigen so that you can add a fluoroquinolone to cover for Legionella. And other thing is role of steroids. Steroids has been in the rise after the COVID pandemic. For every pneumonia, there is a prescription of steroid. If you look at the IDSA recommendation, they are recommending against the use of steroids in community acquired pneumonia except COVID pneumonia. Even in influenza pneumonia, the IDSA recommendation is to avoid the use of steroids because it is associated with increased viremia and increased shedding of the virus. So unless there is another indication for administration of steroids, say a patient is in septic shock or patient is having critical illness related corticosteroid insufficiency, there is no role of using steroids is what the IDSA guidelines say. Still there is overuse of steroids in this scenario. Other is duration of therapy. Patients who are treated on a OPD basis can very well be stopped therapy after 5 days, and in hospital treatment, if they become symptomatically free and afebrile for more than 72 hours, it can be stopped. The duration of therapy rarely goes above 7 days, never above 7 days, at the maximum up to 10 days. But 7 days is the optimal therapy in inpatient setting. So other thing is, how do you prevent it? Are there any vaccines available? So what the recommendation now says is polysaccharide pneumococcal vaccine is recommended for all patients who are more than 65 years of age and who have associated comorbidities. Less than 65 years without comorbidities, it is not recommended, but more than 65, a polysaccharide pneumococcal vaccine is recommended, and the recommendation again is to repeat a dose after 5 to 7 years of the first dose. And other vaccine which has to be taken annually is the influenza vaccine, especially during the monsoon time, preferably during June, July. If we take the monsoon rise of endemic rise in influenza, which we see and which we saw in the last month, also can be prevented. So next is UTA. It's one of the more common infections which we see in OPD basis as well as in the ICUs. The problem between UTA and the community-acquired pneumonia is, community-acquired pneumonia, you know that if there is a pneumonia, you have to treat it. In UTA, you don't know whether you have to treat it or whether it is a colonizer. That is the biggest question, and we always flip on the side of treating rather than not treating. So over-treating also leads to rise of resistance, so we have to be careful about it. Okay. So other thing is, we have to first of all differentiate whether it is a complicated or an uncomplicated UTA. And next is, around 25% of patients who are in a chronic catheterized state will have bacteria. Whether they have associated pyuria or not is different, but they will have 25% of the patient will have bacteria. So that also has to be taken into account. So what are the types of UTA? The uncomplicated UTA is the asymptomatic bacteria as well as your uncomplicated cystitis. What is asymptomatic bacteria? You send a urine for culture because patient gets admitted for some other disease. You send a urinary culture because he is admitted and he grows a 10 to the power 5 colony forming unit, but he doesn't have any urinary symptoms, in the sense he doesn't have any lower urinary tract symptoms in the form of dysuria, frequency or hesitancy, and he doesn't have any fever. So that is asymptomatic bacteria. So what is uncomplicated UTA or uncomplicated cystitis? If they have associated lower urinary tract symptoms, LUTS symptoms, but they are afebrile, that is uncomplicated. What is complicated? So one thing to remember is, every pregnant patient who has a urinary symptom is a complicated UTA, and every male patient who doesn't have any instrumentation done, any male patient who is having a UTA symptom is a complicated UTA. Other things we can easily say, like tumor compression, BPH, stones, or recurrent instrumentation, post-renal transplant, healthcare associated, catheter associated, all these things are complicated UTA. So once it is limited to the lower urinary tract, it is called as UTA. Once it involves the renal parenchyma, it becomes pyelonephritis. In pyelonephritis also you can have uncomplicated as well as complicated pyelonephritis. Complicated pyelonephritis most frequently will require surgical correction, surgical therapy. Okay. So again, the risk factors for UTA, the more or less the same as the previously: diabetes, urinary incontinence. Other thing which you have to remember is the women in the sexually active group are at very high risk of developing urinary tract infection, and as well as patients who have structural or obstructive lesions. It may be intrarenal or it may be extrarenal. They say it may be a tumor which is compressing, or it may be a stone in the kidney. All these can cause urinary tract infection. Okay. So other thing which recently has started increasing is because of the SGLT2 inhibitors, which has been on a rise in the use. Because of concomitant cardiac comorbidities, majority of the patients will be on SGLT2 inhibitors, which causes renal glycosuria, which predisposes all the patients, these patients, to renal urinary tract infection. Okay. So urine analysis, we all look at the urine analysis, we all look at the pus cells, we all look at the bacteria. So we know what is the significant. If you have a leukocyte pus cell count more than 8 to 10, it is significant. If there is no associated, of course, RBCs, and along with that we have to look at specifically leukocyte esterase as well as nitrates. Leukocyte esterase indicates there is active multiplication of WBC as well as nitrates. What is the role of nitrate? If you have a leukocyte esterase positive associated with nitrate positive, so the nitrate test indicates that there is enterobacteria in the urine. If you have a Klebsiella or a E. coli in the urine, more likely E. coli in the urine, so you will have nitrate positive. If you have a nitrate negative leukocyte esterase positive urine with significant pulses, you are looking at more likely a Enterococcus or a Staph saprophyticus related urinary tract infection. So other thing which you have to look at is the colony forming unit, the significance of colony forming unit, and when to do culture and when to do imaging. So colony forming unit, when you send a urine culture from a midstream urine, the 10 to the power 5 rise or 10 to the power 5 rise in a male or catheterized male or a woman is significant. If it is a cystitis, 10 to the power 4 is significant, and if you have an uncomplicated pyelonephritis, 10 to the power 4 is significant. One thing which you have to remember is if you have acute urinary retention patient, you send a sample from suprapubic puncture, any colony forming unit is significant provided the procedure is done in a sterile way. Imaging, so this is based on the European Association of Urology guidelines. Imaging for a urinary tract infection is recommended only if you suspect pyelonephritis or if there is insufficient response to therapy or woman with atypical symptoms, and if you have a pregnant woman. No need of routine ultrasound KUB for all the patients. And next, coming to the causative organisms. Causative organisms can be based on again complicated and uncomplicated. It's more or less easy. Uncomplicated, you have E. coli, which is the most common, followed by Proteus and followed by Staph saprophyticus. And then complicated UTI, majority same organism, but you will have resistance. You have complicated UTI, you will have uncomplicated, same organisms as uncomplicated UTI, but you will have associated resistance because of previous antibody exposure. And recurrent UTI, when you start having a recurrent UTI, that is the time when you start developing hospital acquired infections in the form of multi-drug resistant Klebsiellas and multi-drug resistant Acinetobacter, Enterococcus, as well as catheter associated, you start developing Candidiuria. So when you start antibiotic therapy for a UTI, you have to ask yourself 4 questions. First is does my patient have an infection which requires antibiotic therapy? And if yes, have I sent a culture which has to be followed up and which has to be de-escalated? Next, and if the patient is symptomatically getting better, should I change it from a parenteral to a oral therapy, and how long I have to give? So looking at all those things, we have been speaking about bacteria. So asymptomatic bacteria, we have been telling it need be treated. So how common is it? So it is very common. If you see a healthy premenopausal woman, around 1 to 5%, and patients who are on long-term care and diabetes, around 10 to 30% of the patients. If you send a random, if patient may be asymptomatic, if you send a random urine, they may have bacteria. It doesn't mean that he has to be treated unless the symptoms are there for the urinary tract infection. Better is not to treat it. So why take the risk? Why not to treat? Because the more we treat, more we lose. In the sense that more we lose in the fight against the microbe. The more we treat, the more will be a resistant bug. Then they will develop symptoms, and they will, instead of colonizer, it will high chance that it might become an infection. So all the asymptomatic bacteria, should it be not treated? There are certain specific indications where you have to treat even a asymptomatic bacteria. When do you treat it? Patients who are pregnant. So why do you treat it? It is shown that when you treat a bacteria in a pregnant patient, it decreases or prevents the pyelonephritis, reduces preterm labor and low birth weight, which is particularly important. So any pregnant patient, even if it is asymptomatic bacteria, you have to treat it. And if the patient is undergoing any urological procedure which requires mucosal, which can cause mucosal bleed, then it has to be treated. And any neutropenic patient who has persistently low neutrophil counts less than 1000 for a week, it has to be treated. So asymptomatic bacteria, the routine combinations you can use from cotrimoxazole, in the sense Bactrim you can use, or you can use nitrofurantoin, or you can use a beta-lactam, BL-BLI inhibitors can be used, as well as 3rd generation cephalosporins. So uncomplicated cystitis, again the same. If you have recurrent uncomplicated uncomplicated cystitis, a single dose of fosfomycin 3 gram sachet is a very good drug, and it causes complete cure in majority of the recurrent uncomplicated cystitis. And if you have a complicated or uncomplicated pyelonephritis, majority of the time you will end up giving parenteral therapy, and parenteral therapy, the better is to go for a BLI inhibitors, because high incidence of E. coli, and E. coli majority of the time in the current scenario may be ESBL, so better to go for BLI inhibitors, even though third generation cephalosporins can also be considered. Along with it, fluoroquinolones also has a role. So it's again complicated UTI, majority of the time you will have multi-drug resistance, so you have to go based on the local antibiogram. So majority of the time you might have to go for carbapenems or even higher, sometimes even cholesterol. So catheter associated UTI, when do you say it as COTI? So it is nothing, it is, the definition is more or less similar to a other UTI, only thing is you have a catheter in situ. Either the patient, you have sent a culture from the catheter, or even if you have removed the catheter within the last 48 hours, if you are sending a midstream urine for culture, and if it grows bacteria which is significant, it is catheter associated urinary tract infection. And the treatment principles again is the same, again the colonization is high, and you need not treat it if they are asymptomatic. Only if there is symptoms you treat it. Especially important for candiduria, because nearly 80% of the patients who are chronically catheterized will grow candida, and the only thing which requires is either, if possible, change the Foley's or remove the Foley's. No need of treating a candiduria unless symptomatic or immunocompromised. And a specific word on UTI in males, UTI in males is not very common. So in case if there is recurrent UTI, or if there is a non-responsiveness to therapy, routine therapy for a UTI in a male, you have to look at other complications like strictures or prostatitis and epidermitis and sexually transmitted diseases. So tropical fever, I will not be taking much time about it. It will be it's based on the incidence in the ICUs. It's an INDICAP study which was done in 2017, which was published, a multi-center observational study. You can see among the admissions in ICU, nearly 20% of the admissions are secondary to tropical fevers, and in that around 25% is secondary to dengue. And the most surprising fact of this part of this study was around 20%. The second most common was scrub. So there has been a re-emergence of scrub or in the community, or we have not been looking at the scrub all these days. So the scrub typhus is more common than malaria or even our leptospiro, which we commonly think. So the second most common tropical fever is scrub typhus. And if you see, the mortality in these patients is less compared to the other non-tropical infection, but still it stands at a significant 30%. This is for ICU setting, but still it's quite a high number. So we'll have a brief word about all the most common 2-3 tropical fevers. One is the major thing is, based on this study, what the ISCCM or the Indian Society of Critical Care Medicine did was they developed a syndromic approach for the tropical fevers. So we will look into it in the later slides. So why they looked at a syndromic approach? Because they have overlapping symptoms. We will have very difficult diagnosis of a tropical fever. Majority of them will have fever, myalgia associated with a capillary leak leading to ARDS. They will have thrombocytopenia. They will have mild deranged RFTs and LFTs. We will be in a question, and we will be sending all the tropical workup, and majority it will take around 3 to 5 days to get the result. So how to treat them empirically? That is the rationale behind why a syndromic approach was formed. So there are certain points which will help you in diagnosis of particular disease, especially the eschar. As we all know, if the black eschar is present, it is suggestive of scrub typhus. If you have a conjunctival suffusion followed by a mild deranged LFT with bilirubin on the higher side, then it is more likely a leptospira if it is associated with significant myalgia. If you have a breakbone fever, in the sense that if you have a severe headache associated with it, and after 3 or 4 days if the patient develops thrombocytopenia, we may conclude it is dengue. But definitive diagnosis, unless you have a serological diagnosis, you cannot come to a conclusion, and you have to treat them empirically for all the tropical fevers. So leptospirosis, a brief word on it. It is a zoonotic disease. The only good thing is it is a dead-end infection in the humans. Usually it's from the contaminated urine, it infects the humans, and it's a dead-end infection in the urine. And the CDC estimates around 1 million cases annually with 60,000 deaths, which is a quite significant number. And dengue, now the terminology has been updated by the WHO 2018. There is no further dengue shock syndrome or dengue hemorrhagic fever. All comes under severe dengue. You have either a probable dengue, then you have a laboratory confirmation, then you have a laboratory confirmed dengue, then you look for warning signs. Warning signs in the form of mucosal bleed, abdominal pain, headache, then you look at dengue plus warning sign. If the dengue positive, along with you have a sequestration or a severe bleeding or end organ damage, it becomes severe dengue. So dengue hemorrhagic fever as well as dengue shock syndrome now comes under dengue, severe dengue. This is just to relieve people of the confusion. Okay, so the dengue clinical course of illness, we all know it is during the effervescence of the disease when the patient starts to manifest symptoms. Scrub typhus, a brief word, it is caused by Orientia schutzschugamusi by the followed by a bite by the trombiculid mite. So chigger, which can cause the scrub typhus. The pathognomonic sign is the black eschar, which is secondary to the organism invading the vessel and causing a necrosis, which leads to the black eschar. The highlighting point here is this black eschar will not be painful, it will not be pruritic. So that is why the patient will not tell, you have to actively look for it. And other thing is, this is called as the Shutshugamushi triangle, which extends from the Iran and Pakistan in the west to all the way to Japan and Russia in the east and the northern Australia, and this is where the highest number of around 1 million of cases of scrub typhus are diagnosed every year. So coming back to the topic which I spoke earlier, it's why the syndromic approach. Because of the overlapping symptoms, it is better to treat them as a syndrome. So how did they name the syndrome as? They named it as undifferentiated fever. So again, fever with thrombocytopenia, fever with jaundice, or fever with multi-organ dysfunction, fever with encephalopathy, and fever with respiratory distress. If you have an undifferentiated fever, you don't start them on any empirical antibiotic. You just give supportive therapy. You give them, you take care of the ABC, you take care of the hemodynamics, you adequately rehydrate them and closely monitor them. If you have a fever with thrombocytopenia, the assumption is it's more likely a dengue. So you correct the ABCs, antipyretics, SOS, and withhold and the antiplatelets and platelet transfusion SOS without any antibiotics. When you have other multi-organ dysfunction in the form of liver dysfunction or renal dysfunction, that is when you should think about adding them on empirical antibiotic. What is the empirical antibiotic recommended? Ceftriaxone plus doxycycline is what is recommended. It will cover both leptospira as well as scrub typhus. The doxycycline resistant scrub typhus is on the rise, but if you suspect doxycycline resistance in scrub typhus, you can go for high dose azithromycin or rifampicin, which is not advisable in our setting, but azithromycin is a good alternative for doxycycline. So if you have encephalopathy, so then you have to broaden your spectrum. You have to look at other tropical fever also, probably a malaria, maybe a associated meningitis or encephalitis. So you have to go for viral cover along with ceftriaxone and doxy. You go for acyclovir until you get a definitive diagnosis by CSF, ruling out a viral encephalitis, or if you prove it is a aseptic meningitis, then the antiviral can be de-escalated. So then fever with respiratory distress. Fever with respiratory distress, usually ARDS secondary to capillary can be treated the same way with ceftriaxone and doxycycline. Sometimes a MRSA cover may be required. So this is in a nutshell the management of fever with encephalopathy as a syndrome. You rule out all the other reversible causes, look at the hydration, maintain the hemodynamics, look at the glucose levels, and then if there is no lateralizing or focal signs, then do a LP. If there are raised features of raised ICP, look at the imaging to rule out the raised ICP, then do a LP. Based on the LP, you treat further. Till you get to a definitive diagnosis, treat them empirically with ceftriaxone, doxycycline and azithromycin. And if you have high suspicion of malaria, give artesunate based therapy also. So, briefly discussed about the infection, so we will look into the antibiotics as such. So, antimicrobial resistance, it has been the talk of the entire medical fraternity for nearly a decade now, and have we done enough to reduce the antimicrobial resistance? Certainly I don't think so. But we will look into what are the mechanisms of resistance and how we can address it, and what are MDR and XDR organisms. So what is antimicrobial resistance? There are two types of resistance. There are certain antibiotics or certain bugs which are inherently resistant to antibiotics. Say a Pseudomonas is inherently resistant to tetracycline. That doesn't mean that it is a MDR organism. You don't look at inherent resistance. It is the acquired resistance which we are worried about. Protease is inherently resistant to colistin. Stenotrophomonas is inherently resistant to carbapenem. So these are not looked at as resistant. These are all inherent properties of the microorganisms. What we are worried about is acquired resistance. Okay. So before looking at it, we will look at the looking into the resistance mechanism. We will look at the differences between GNB and GPC as such. Okay. So GNB, which is of particular interest in India because we don't see much of GPC. GNB has an outer membrane and a peptidoglycan layer followed by a cytoplasmic membrane. So it is the outer membrane which gives the protection in the GNB, whereas the gram-positive bacterium will not have an outer membrane. It has a thick peptidoglycan layer which forms the cell wall instead of an outer membrane in a GNB. So, and the plasma membrane as similar. So the resistance mechanism are different in both the group of bacteria. So you have peptidoglycan layer which has the penicillin binding protein. So the penicillin alteration in the penicillin binding protein is the major form of resistance in gram-positive bacteria, whereas in gram-negative bacteria the mechanism of resistance is multifactorial. So you can have decreased antibiotic entry which could be secondary to reduced pore-in channel mutation. Because of pore-in channel mutation, the antibiotic may not be able to enter. And then there is efflux pumps which might be there, which might reduce, which might push out the antibiotics which enters the cell, and there can be altered binding site of the antibiotic, which is particularly important in fluoroquinolones, where DNA gyrase and topoisomerase gets altered and your fluoroquinolones will never act. And the most important part is the beta lactamases or deactivating enzymes, which is the thing which is being studied more and more commonly because it is the most common form of resistance in gram-negative bacilli. So drug-resistant bacteria, how do we define them? MDR, XDR and PDR. So what is MDR? You have a acquired resistance to one agent in one of the first-line antibiotics. When you have a acquired resistance to one of the first-line antibiotics, it itself is called as multi-drug resistance. When you have acquired resistance to at least one agent in all except two group of antibiotics, then it becomes extensive drug resistant. If you have resistance to all classes of antibiotics, it becomes pan-drug resistant. So majority of the time we are looking at, as far as ICUs are concerned, we are looking at XDR and to an extent PDR drugs. So Ambler classification, this is regarding the beta lactamases. It may look very tough, or it may look why we have to look at these genomic values, but once we start using it, it will make a lot of sense. So beta lactamases based on the Amblers are classified into 4 types, which is A, B, C and D. So in this A, C, D are called as serine beta lactamases because it doesn't have, the active site is a serine. So the type B beta lactamase is called as metallobeta lactamase because the active site is a zinc. So why we are worried about B? B is inherent to India because the metallobeta lactamase B is the New Delhi beta lactamase which is resistant to majority of the antibiotics which we use, and majority of them are carbapenem resistant, meropenem, imipenem and doripenem resistant. So the penicillinase can be, it can be just a penicillin resistant bug, or it can be a KPC. KPC is again a carbapenemase resistant one. Type C you can remember easily as cephalosporinases. It is called as pan-cephalosporinases. So it is AMC. If you have type C beta lactamase, it will be resistant to all the cephalosporins. Type D is OXA. OXA is for oxacillinases. So it is resistant to majority of the beta lactamase. It will look tough, but if you use it practically, it will serve a lot of purpose. So the basis for why I was mentioning all these things is because of this newer diagnostic, syndrome-based PCR-based assays, because the majority of the resistance are because of the inappropriate antimicrobial empirical therapy. So we have to cut down on the time from a empirical therapy to a definitive therapy. If you go for PCR-based diagnostics, If you go for PCR based diagnosis, you get the result in 5 to 6 hours. So you need not go for an empirical therapy, you can go for a definitive therapy. So what they did was, if you have a community acquired pneumonia, they clubbed 20 more likely organisms, both bacteria as well as viri, into a pool, and they do it as a multiplex PCR, and if you find out any organism in that, you try to treat it. It can be for respiratory panel, it can be for lower respiratory tract, it can be for gastrointestinal, it can be for blood, and it can be for meninges. So the previous deficit with this PCR was, the PCR was giving you only an organism. It will give you an organism based on the PCR that this patient is growing, say, Streptococcus pneumonia, or the patient is growing Acinetobacter. We will not be able to know the resistance mechanism. So that's where these genes come into play. Once they got to know the genomic sequencing, what they did was they incorporated these genomes into this PCR. So once the PCR study comes, you will get the genomes which are involved. So once you get a, say if you get a Klebsiella with the associated genome being KPC, you know that it is going to be a carbapenemase resistant. So these are all the common things which you have to remember, which had made the work of an intensivist very easy, or it has made a lot of difference in treating empirically. So just a nutshell, what you can remember is the ESBL, which we say as extended spectrum beta lactamase. The most common enzyme or the most common genome is CTXM. So if you have a send a PCR and the bacteria grows CTXM, then you can say that it is a ESBL E. coli. 3 days after, you will get a culture which says it is ESBL E. coli. So you can treat them with a carbapenem or a beta lactam inhibitor. So you have a TEM. TEM is a penicillinase. You need not even go for a carbapenemase. If you have a KPC, you know that it is going to be Klebsiella, you can treat it accordingly. So this is the advantage of using this PCR based assays. So, so we understood about the resistance. So how to optimize the therapy based on the PKPD principles. So what is PKPD? PKPD is nothing but pharmacokinetic is what the body does to the drug, and pharmacodynamic is what the drug does to the body. So role of antibiotics, if you can see, the discovery of the antibiotics was the biggest game changer in the medical field itself, because you see the decline of death secondary to the discovery of antibiotics is nearly 5 to 10 folds higher than any other intervention till in the medical history. So that is the importance of antibiotics, and that is becoming more and more resistant. Okay. So, and it's a sad image where we have the majority of the antibiotic usage. If you see, we are in the highest antibiotic consuming category, and nearly, if I'm not wrong, the data says that around 30% of the whole carbapenem usage around the world is by India. So what are the 4 R's of antimicrobial? You give the antibiotic the right drug at the right dose at the right time for a right duration, you will get a satisfactory result. Okay. So this is the same. So the PK is what it includes absorption, distribution, and elimination. So this is the plasma concentration time curve. So this is the pharmacokinetic, and this is the dose response curve. And when you do a proper pharmacokinetic and pharmacodynamic therapy, you get something called as this, which is the effect into time, which is the outcome. Okay. So once you give a drug, so there is a peak concentrations. Once it reaches the peak concentration, the plasma concentration starts coming down below the MIC. So this is the MIC. So what is MIC? It is the minimum inhibitory concentration to prevent the growth of a microorganism or a bacteria. So based on this graph, you have 3 models of pharmacokinetic principles. One is the peak. So what you can do, there is something called as Cmax by MIC, which is called as concentration dependent killing. Next is the time above the MIC. So it is the duration, the antibiotic concentration is more in the blood than the MIC, which is significant. That is called as time dependent killing. Then there is the area under the curve. It is a sum of both the time as well as the concentration. In other words, it is a it depends on the total dose of the drug which is being given. Okay. So concentration dependent killing depends on a single maximum dose, so that your peak is very high. So your Cmax is very high. The Cmax should be 8 to 10 times the MIC for it to have good activity against the bacterium. So the typical example is your fluoroquinolone and aminoglycoside. You give a single large dose, you have a high Cmax, you have a Cmax by MIC more than 10, you will have good results. So how does it affect? It's for a very short duration, but there is something called as post-antibiotic effect. Because of that, the bacterium, even though the concentration is less than the MIC, the bacterium will be inhibited. It is post-antibiotic effect is very well noticed in fluoroquinolones as well as in aminoglycosides. So next is, so this is what, you give a single large dose, you target a Cmax by MIC of more than 8 and you will get good results. Next is time dependent killing. The typical example is your beta-lactam. So what you do, you split the dose and give it as a prolonged infusion. It is the duration of time, the plasma concentration is above the MIC, which is important here. So if small example here, so if you give it as a single dose, you have a peak and it comes down, your time above the MIC is very low here. So if you give it as a prolonged infusion, say from 30 minutes to 4 hours, the time above the MIC is very high. So you will have better results. Even though the bug is sensitive, you may not have a good response here, but you will have a better response here. Okay. So the practical implication, better always to give beta-lactams as continuous infusion. You can ask why the drug cannot be given as a 24-hour infusion. If you give the infusion more than 4 hours, there is high chance that it might get denatured because of dilution. It might become unstable. So preferably over 3 hours is the recommended time. Next is area under the curve by MIC. So it is a sum of the dose. So the higher the dose you give, higher will be the area under the curve. So what you do is you give high dose as well as split it up. The typical example is vancomycin. Either you give 1 gram BD or 1.5 gram BD, so that you give higher dosage, so that the area under the curve will also be higher and your activity will be better. So similar is colistin and vancomycin. Here this is an example why a loading dose is must in majority of the inpatients, because if you give without a loading dose, it takes nearly 48 hours for your drug to reach the plasma concentration. Desired plasma concentration of 2, it takes nearly 48 hours. Once you give a loading dose of say whatever, for colistin it's 9 million, when you give a loading dose, it reaches it less than 12 hours. That is why loading dose is very important, especially in inpatients. So the next is the sad part which we are facing. We don't have any the pipeline is dry is what we used to say. There are no upcoming antibiotics for these resistant bugs, especially gram-negative bacilli, because the West is full of gram-positive bacilli. They have a lot of antibiotics for the gram-positive already. So we don't have much of drugs, and the majority of the newer antibiotics which I have mentioned is not even available in India, except ceftazidime avibactam, meropenem vaborbactam or imipenem relabactam or any of these things. None of these things are available in India. The even more sad part is none of these is active against the NDM which I showed, the New Delhi metalabitolactam. None of these agents are active against NDM. The only drug which is left which is active against NDM is aztreonam and colistin. All other things are majoritarily doesn't act against the NDM. So that is the sad part which we are facing. This plasmomycin, which is aminoglycoside derivative, may have some activity is what they say. So how to protect these antibiotics? So always treat the infection. If they are symptomatic, treat it. If it is a colonizer, don't treat it. That is the only way we can save ourselves, not the antibiotics. And if you look at, this is what I was saying, the harvest is very low. All the antibiotics which we are using are from nearly 4 or 5 decades ago. Even colistin was used in 1970s and it was stopped because of its toxicity. Now we don't have an option, so we are using it. There is no newer antibiotics down the pipeline. So in the Nobel speech, when he was the Nobel laureate Alexander Fleming, in his speech he had a prophecy probably. He told in 1945 that a time may come when penicillin can be bought by anyone in the shop, and then there is the danger that the ignorant man can easily underdose and can lead to resistance. This was said by him when he discovered penicillin nearly 8 decades ago, and still I think we still do that. Thank you.
there any way that we can stop the antibiotic usage at the GP level, even for small? Is there any drive against that? Because that is the most worrisome of everything that happens, you know. Everybody, and over the counter also, anybody who comes to us says, Madam, I took azithromycin 2 days, nothing happened, so I have come to you. So, and that simply looks like a virus. You just have to give weight-based paracetamol and some ranitidine and send him. Somebody has an answer for that, I'll be.
Actually, the drive is coming from Chennai. If only you know you are part of the family physicians group. Or we keep posting what the kind of initiatives we are doing from the infectious disease point of view. We keep posting, urging the family physicians. We are the gatekeepers in this big war which we are going to face in the coming decades. We have seen the COVID, but this is just the priming. I'm going to say you that in the next coming decades, we will be seeing only the MDR bugs without any antibiotics, as Dr. Ayyappan was mentioning. So some of the initiatives are taken up by the ID physicians from Chennai, and we're approaching the Drug Controller of India, urging them to not to let these pharmacies to give away all the antibiotics without our prescription. But we need to understand this nitty-gritties involved in between, given the fact that all of the people can't approach a family physician, pay a fee for prescription and go. But it is going to happen. One is that. Second, what we can do as a family physician is like, as Dr. Ayyappan was clearly mentioning there, asking for the cultures. What we are treating, whether we are treating bacteria, whether it is a sensitive bacteria. As he already mentioned, antibiogram. Madurai la namma UTI urine infection ku endha bacteria nariya irukku namma area la. And the bacteria enna marundu kudutha gamnu poidum. Idha naama vandittu oru antibiograma area wise cultures nu kondu vanduttonna any IMA meetings you can say enga hospital pakkathula this is the kind of bacteria we are seeing in urine. This is the kind of typhoid we are seeing in our hospital. Indukku இந்த மருந்து கொடுத்தாவே கேட்டிடுது. GPs, you also follow the same. This is called antibiogram. When will it happen? When we start asking for cultures. Not blindly giving amoxicillin clavulanic acid or levofloxacin or ciprofloxacin in our clinic, which I was doing 2 decades ago. Now I started seeing I am harvesting the results because I am seeing the bugs, which is saying I won't be going away with all this antibiotics you are giving me. So as a family physician, urine infection vandanganna, I ask the patients to give the sample, store it in the refrigerator, give the sample the next day to the good microbiology or any hospitals like Meenakshi Mission, nearby hospital, give it to them. Ask for the antibiogram. Keep storing it in your Excel. See which bacteria and the antibiotic sensitive, which bacteria and antibiotic sensitive. Down 3 lane or quarterly, you will know. என்னோட ஏரியால இந்த பாக்டீரியா தான் இருக்கு, இதுக்கு இந்த ஆன்டிபயோட்டிக் கொடுத்தாலே போதும். You will be the winner. You will know how to get him out of this place or how to revenge this MDRs you are going to see. And Dr. Ayyappan won't be seeing this kind of MDR bugs. He will say the reversal happening. This is what happened in Switzerland. This is a very small country where a couple of decades ago itself they did it. When they started seeing this uprising of this MDR happening, they started doing the antibiogram. They started urging the family physicians, do the culture. See what you're treating. Don't treat unnecessarily. So they started cutting down. And the other thing is like, we can do something called cycling of the antibiotics. So oru varshathukku we will use amoxiclav, adutha varshathukku we use Bactrim DS. ஸோ அந்த மாதிரி வந்துட்டு இப்போ ரெண்டு பாக்டீரியா ரெண்டு ஆன்டிபயோட்டிக் சென்சிட்டிவாக இருக்குன்னா the IMAs in the meeting we have to say, okay, this time this is the antibiogram, the next time we have to start changing it, change the weapon. So the bacteria which starts telling its the family or other bacteria, because they talk to each other, right? So they will say, this is a resistant mechanism we have to follow, like covering up the protein, penicillin binding proteins or efflux pumps. அவங்க ஒரு ரெசிஸ்டன்ட் மெக்கானிசம் பண்ணுவாங்க, பட் வி சேஞ்ச் த target the next time. So call recycling of the or reversal of the antibiotics or changing the antibiotics. I think we are the gatekeepers in this, and I think with this kind of initiatives, like with lectures like with Dr. Ayyappan, I think we will take up the thing further. What do you say?
Ma'am, I'm practicing in near out rural places where most of the people who are giving antibiotics are more like RMPs and non-medical people. The strange thing which I have observed is all those RMPs around me, they start giving same antibiotic which I am using. This I have been observing since a long time. Whenever I write ampicillin, they switch out to ampicillin. Whenever I write levofloxacin, they switch out to levofloxacin. After this COVID, where we have stopped using antibiotics, even I have started my patients not to take antibiotics for initial 2 to 3 days of any infection. Any infection, let it be bacterial or viral, clinically I assess and I ask them not to take antibiotics until your fever is more than 48 hours. Strangely, all the RMPs have stopped using the antibiotics. See, actually there is one statement in Sanskrit, Yat acharati shrestha, tat deve tatara itarajana. That means, whatever the king practices, the people also follow the same thing. So if we control ourselves, if we stop using unnecessary antibiotics, definitely people around will stop using those antibiotics. Sir, Ayyappan sir, if you just forgive me, I will ask you one basic question. Sir, you said that there are more gram-negative bacteria, particularly in our country. Sir, generally what antibiotic we are using, like basically including ampicillin, ciprofloxacin, they are having good gram-negative coverage, right sir? So do we need to give more than what we are giving, or what we are doing is enough?
No, generally what we are giving covers the spectrum which we encounter. So when we use third generation cephalosporin or when we use fluoroquinolones, majority of them have good gram-negative cover. So that should suffice.
Sir, and one more question. You have said piperacin tazobactam should be given in 6th hourly dosage for Pseudomonas coverage. Sir, should it be given only 6th hourly for having Pseudomonas coverage, or it can be given thrice daily?
See, basically it is depending on the target site. So it depends on where the source of your infection is. If you have a urinary tract infection, your plasma concentration which you give, the piperacillin tazobactam which you give, will reach the urine at a higher level. So your tissue concentration will be high for urine. So even if you give 8th hourly, it may suffix. Whereas if you are treating a bug in the lung, your lung parenchymal concentration, the tissue breakdown point which we used to say, will not be as high as in the urine, because it gets eliminated in the urine. That's why you have the best outcomes with the urinary tract infections. You have always good outcomes. When I have a sepsis patient in ICU, I prefer urinary tract infection because they will have the best results. Even if they are intermediate, even if you give an antibiotic at the appropriate dose, your concentration in the urine will be so high that it will get eliminated, the bacteria. But in the lung, it will not be the same. So if you are treating Pseudomonas in urine, which is very rare, TDS will be enough. But if you are treating Pseudomonas in the lung, then a 6th hourly will be required. Either 3.375 6th hourly or 4.3.
This is with regard to your suggestion about antibiogram and culture.
Yes, sir.
Can I suggest that the Infectious Disease Society is a project maybe funded by ICMR, where you recruit GPs from every district and you tell them you will fund the culture and over time you will get the antibiogram also. Because one limitation could be that many GPs may not be able to do the culture because it's expensive. Patients say, no, I can't afford. And if you can do that as a project, that over time, you pay for it, but they do the culture and you also get the antibiogram, which it has to be done every year, I suppose. Yeah.
Definitely, sir.
Hello, sir. Good morning. That was a wonderful talk. Sir, may I know the timing of doxycycline empirically, when to be started, And second thing, role of steroids in tropical fever. I have too many questions. I'll limit for this.
Steroids in tropical fever doesn't have much role unless the patient is in shock. If the patient is in shock and if it is vasoplegic, then steroids may be considered. No empirical role of steroids in tropical fever. Doxycycline as the first choice. You give ceftriaxone when you suspect a tropical fever, in the sense that you have a patient who has an undifferentiated fever with a skin rash, or if the patient is having a blood picture of thrombocytopenia, start ceftriaxone and doxycycline together at the earliest. You need not wait for the report, because earlier the therapy betters the outcomes, especially in tropical fever.
Thank you, sir.
Thank you. A wonderful session and wonderful comments from the chairpersons as well. I just wanted to add one perspective here, which I think is missing. If we look at antimicrobial resistance as a public problem, the contribution of physician prescriptions is sometimes, I mean, I absolutely advocate for rational antimicrobial usage by us. But if you look at this, this is actually also an environmental problem. In Bangalore, we did a large wastewater surveillance project looking at what bacteria and what patterns of antibiotic resistance were found in the sewage. You find very high levels of ESP ulcers, Klebsiella especially, which are CREs, that is carbapenem resistance enzyme producers. So one of the things that you will see when you especially send urine cultures, patients with UTI for urine culture, is even in community practice, especially in larger cities, even who have had no exposure to the hospital environment or no recent antibiotic exposure, you will find very high levels of resistance. So what people estimate is that only about 15%, 7 to 15% of antimicrobial resistance at the society level is because of physician prescriptions. The largest proportion actually comes from the use of antibiotics in poultry, in animal husbandry, in basically those sectors. And also if you look at the policy framework, antibiotics in India come under the Department of Chemicals and Fertilizers. They don't come under the health department. So you can imagine that there are various other systems problems which are amplifying and contributing to antimicrobial resistance. So while I absolutely second and congratulate the excellent suggestions, we have to also be aware of the larger context of this problem. Thank you.
Thank you. As we are running out of time.
So I'm Dr. Subhashankareshwari from Chennai. Your presentation is so clear and very neat presentation. But one small request, let us be synonymous. Instead of monotonous presentation, maybe once in every 15 minutes, you can interact us or we'll give something.
Thank you for your suggestion.
Thank you.
You want this presentation to be more
it cannot be monotonous.
Yeah.
As the audience, traveling from Chennai, we will feel sleepy in between. So, so I thought it could be something reciprocative. That's it.
Sure. We'll try to make it more interactive. Thank you for your suggestion. As we are running out of time, we'll move on to the next session. All queries, you can mail it to Dr. Ayyappan. He'll share his email ID with you. Or you can email any of the committee from here. Okay?
Thank you, sir. Now I would like to request Dr. S. Kumar, cardiac anesthetist, Meenakshi Mission Hospital and Research Center, Madurai, to honor the speaker and the chairpersons. Thank you, sir.